Hey everyone, welcome to Healthcare Reimbursement. This first chapter, we're going to talk all about the revenue cycle management. So when I say revenue cycle, I'm talking about from when a patient checks in at a doctor's office or hospital until after the final payment or denial is made, and all of the steps in between. Okay. Before the 1930s, people had to pay out of pocket for their health care on what's called a fee-for-service basis. So at the time you receive your care, you have to pay for everything they're doing. There was a hospital administrator at Baylor University that noticed, the average person couldn't afford to pay all these medical bills, and it was becoming a problem. So they partnered with a group called Blue Cross Blue Shield. You've probably heard of them. They had a different name at the time, but to work together to create a plan to help people pay these bills. And this caught on really quickly across the country. Other health plans started to be created, mostly group policies, which are offered by employers or unions, okay? But older people and people with lower incomes that didn't have access to these group policies were still struggling. So in 1965, the Social Security Act was amended to add Medicare and Medicaid. And that brings us to what we have today. But there are still a lot of challenges within the U.S. healthcare system, such as the rising cost of healthcare. Also, the need to improve quality and safety for patients. And, excuse me, also the coordination of and accountability of care and services between providers and payers. Okay, so I think the first two bullets are self-explanatory, but the last one is basically saying that the systems in place to pay providers they're really complex. So it's important that the claims are accurate to show exactly what services are provided to a patient, and the reasoning for those services, something called medical necessity. Okay. The Health Insurance Portability and Accountability Act, or HIPAA, is one of the most prominent laws regarding healthcare. If you've ever gone to a doctor's office or the hospital, you have signed a HIPAA consent. So it covers a lot of stuff. A big one is that it protects your privacy as a patient. It also covers specifically how a doctor or provider can send your health information to an insurance company for payment. Okay. Healthcare providers are the doctors and such that send in health claims and get paid for their services, right? The health plans are the individual or group insurance plans that pay for this medical care. So we have things called healthcare clearinghouses. They're like the middleman between the providers and the health plans. They're the only HIPAA-covered entities that can check these claims from doctors to make sure there's no errors. Another thing they do is they'll change the format from non-standard. So the claim is sent from the doctor in this non-standard format, and they'll change it to a standard format and send them to the healthcare plans for payment. So really, they just help to speed up the process. Covered entities are healthcare organizations that are required to comply with HIPAA. So this would be any organization that electronically submits any information that's protected by HIPAA. Okay, under HIPAA, providers cannot release your PHI or your protected health information to anyone other than you or your authorized representative without your written consent. There are two parts to HIPAA, the privacy rule and the security rule. Okay, we'll get into those a little bit. The privacy rule covers the physical, so think privacy, P, physical, P, the physical security and confidentiality of your PHI in all formats So paper, electronic, oral, etc. Here's just some of the things that are included in your PHI. So your name, address, date of birth, names of relatives, employers, email address, phone numbers. Okay, so these are the types of things that are included in your PHI. Okay, the HIPAA privacy rule allows your PHI to be released without your consent for these things here. Okay, so wait, what just happened? I just said under HIPAA, your PHI can't be released without your consent. So how does this work? The privacy rule states that these are the only times it can be released without your consent. So for treatment, if you're seeing two different doctors, they have to be able to discuss your options and, look at the scans this doctor did so they can get the full picture and give you the best treatment. Okay, for payment, so doctors have to be able to send some of your PHI to these insurance companies so they can get paid. For healthcare operations, not operations like surgeries. This is talking about doing like quality assessments to make sure you're getting the best quality of care and to make sure there's no fraud or abuse going on. And then to ensure public health and safety. So this would be like if there's a disease outbreak in a community that has to be monitored by the public health authorities to keep everyone safe. Okay. Individually identifiable health information is any information that could identify someone specifically. So where the privacy rule covers PHI in all formats, the security rule specifically covers anything in electronic form, and it's referred to as ePHI. So covered entities have to have administrative, physical, and technical safeguards in place to protect ePHI. Administrative meaning making sure all staff are properly trained, all of the policies and procedures are in place and updated regularly. Physical would be physically protecting the computers and the workstations and having like security devices to get into certain areas, like where they have to like badge in. And then technical safeguards make sure only the people that need to access PHI can do so. That ePHI is transmitted safely over the network, etc. Minimum necessary is another part of HIPAA that says, okay, if you have to disclose PHI to another provider for treatment, then you can only send the minimum amount of PHI necessary that they would need. The only exception would be psychotherapy notes. These have to have the patient's written authorization, okay? So I think HIPAA is most known for protecting health information, but a big part of it focuses on preventing fraud and abuse. They did this by creating the Medicare Integrity Program that looks over providers' claims and payments to find any fraud and abuse. The False Claims Act actually began during the Civil War, and it prohibits federal contractors from knowingly filing a fraudulent claim to defraud the U.S. government or get more money than they're supposed to. And that led to more recent laws like the Medicare and Medicaid Patient and Program Protection Act of 1987. This law added fines that have to be paid for any of this Medicaid or Medicare fraud. And they're not small fines. The government does not like for you to take their money, okay? Then in 1995, Operation Restore Trust was created to target healthcare providers that were committing fraud and abuse. So what is fraud and abuse? According to CMS, fraud is knowingly submitting false claims or making misrepresentations to obtain payment for which no entitlement otherwise exists. That's straight from their website. So purposefully billing for services that are a little more complex than what the doctor actually did. or billing for services or supplies that weren't used, or billing for appointments that the patient didn't show up for, okay? And abuse would be any practices that directly or indirectly result in unnecessary costs to Medicare. So this would be billing for unnecessary services, excessive charges for services, or upcoding or unbundling on a claim. Okay, you can explain the difference between fraud and abuse on your own if you'd like. We're going to keep going. Okay, the revenue cycle has 3 parts. The front end of the revenue cycle is where payer negotiations take place. So this is before a patient even sees their provider. The third-party payer and providers have these negotiations where they decide on what the payment rates are going to be. Also, appointment scheduling and insurance verification happen in this part as well. The middle part is where the care is actually provided. So the patient is seeing the doctor. Everything that's done is being documented. When the patient checks out of the office, the charges are captured on an encounter form, and diagnoses and procedure codes are coded, and then everything's transferred to a CMS 1500 claim form and sent to a clearinghouse. Remember, a clearinghouse, that's that middleman that's checking the claim and changing the format. Then the clearinghouse is going to send that to the payer. And really all doctors are trying, or providers are trying to submit what's called a clean claim, which just means there's no errors. They didn't leave any information out, okay? Let's see. Okay, the back end, let's see. Oh, sorry, I got ahead. The back end part is where the claim is processed and sent to the payer. Then the provider will get their payment, which they post to accounts receivable. Or if the claim gets denied, this is where they would check it for any errors in coding and see if anything is missing. And then they can either send a corrected claim or file an appeal. We'll talk about appeals later on in the semester. When the third-party payer receives the claim, first they're going to make sure that the patient is actually covered by their insurance. The very next thing they're looking for is that medical necessity. That is so important. Let's see. Okay. You can, if it's not really on this slide, but if y'all want to take notes. So they want to make sure, what the patient had done was medically necessary. And if they can't find that, they're not going to pay it. They're also checking to see what the patient's deductible is, what their copay and coinsurance is, so they know how much the third party payer should pay, and then what the patient also owes. So this process of comparing the claim to the patient's health plan is called claims adjudication. Okay, that first thing there down at the bottom. Okay, once the third party payer pays the claim, they will send a remittance advice along with the payment to the provider. This remittance advice is usually in batch form, meaning a bunch of patients will be on the same one, and it just explains what they paid for each patient. At the same time, the third-party payer will also send out an explanation of benefits, or EOB, to the patient. So y'all have probably gotten these before. And it's doing basically the same thing. It'll have what your deductible is, how much you still owe, or if you've met it. It'll say how much was paid to the doctor, and what they owe, what you owe. If you have your own insurance, then you know what I'm talking about. All right. Here's some other key terms Capitation is the amount that is agreed on ahead of time that the doctor will make on a monthly or yearly basis to treat patients. And then a fee schedule is the list of how much a third-party payer will pay for each service. Okay. The Health Information Management Department plays a big role in the revenue cycle. The coders are the ones that are actually looking in the patient records and assigning diagnosis and procedural codes. And then after everything is coded, the HIM department is also making sure that there's documentation in the record to support those codes. This next thing is kind of strange. You'll also learn this if you're in my healthcare law class. But as far as the medical record goes, the physical medical record, if it's paper or the actual electronic health record, is owned by the hospital or the doctor's office or whatever facility it was created in. So you as the patient own the health information in it. But the facility, the provider, etc., they own the actual medical record. So, for example, I knew of a doctor that retired and closed his practice. This was years ago, so they only had paper charts. But he had to take all of his patient charts, physical charts, and store them in his garage until the date that they could be destroyed. So because he still owned those records. So just remember that, hint, hint. You own the information, but the provider owns the medical record. Okay. Let's see. All right. So diagnosis and procedural coding. So this is where numeric and alphanumeric, so letters and numbers, codes are assigned to diseases, injuries, surgical procedures, and supplies that are used. So there's two different sets of coding schemes that are used. We have the clinical classification systems. These are used for reimbursement, obviously, but also they use the codes to make reports related to public health and quality control. They use them to do research and for education. And then also monitoring the performance of both doctors and the hospitals. So this would be ICD-10-CM, ICD-10-PCS, and CPT. Clinical terminologies is more on the front end. So SNOMED CT is used around the world in healthcare. You can think of this as like a programming language to put clinical findings, which can include diagnoses, procedures, health outcomes, into electronic health record systems. So you're probably like, how is that any different from the first thing? Think of this like a universal language. And SNOMED is putting info into EHRs, whereas ICD-10-CM or PCS is taking the information out of the EHR and assigning the codes. I hope that makes sense. Okay, so those are the traditional roles that HIM has played in the revenue cycle. But as technology has expanded in hospitals, there are new roles for HIM professionals like those listed here. Okay, so charge master analyst, revenue integrity specialist, PPS coordinator, director of revenue cycle management. We're not going to go into what all of these positions do, but if one of these interests you, you can look into them more. On AHIMA's website, they have a career map. You can go to www.ahima.org/career map, and you can check that out. Okay, because technology is always changing, the revenue cycle is probably going to be continuously changing as well. So this will be really helpful, but could potentially create some challenges in these roles because you're always having to like adapt to the new, whatever the new thing is. So to try to combat some of these challenges, hospitals are looking to artificial intelligence in the form of robotic process automation to kind of like fill in the gaps, and then also to cut costs across the revenue cycle. So this would be for like repetitive tasks, like pre-registering patients or prompting patients for more info if they forget to fill something in, so that people, like physical people, don't have to focus on things like that and they can work in other areas where they're needed. Another technology that's being used more is predictive analytics, and they're using this to try to forecast or to predict revenue. So they can try to correct problems that would affect their revenue before they even occur. Okay, and this graph, here we go. This little graphic shows you the revenue cycle. So if you're a visual learner like me, then this may be helpful for you to see it this way. So feel free to pause the video and check it out. But that's all I have for you today. So email me if you have any questions, and I hope you have a great week. Bye.